rotate in circles to the left or to the right, they don't understand that either. So they don't understand that they're doing that. They have no idea. Now I can move on. All right. So with vestibular system dysfunction, I'm talking about within the peripheral vestibular system, you have three different types or subcategories that I want to discuss with you that when you're in the clinic, you may encounter, or you might be partnered with a physical therapist who specializes in vestibular system issues. So it's nice to know the basic terminology that goes along with vestibular dysfunction. So the mechanical vestibular dysfunction is a BPPV that's called benign paroxysmal positional vertigo. Okay. And we have two different forms. One is called a cupulolithiasis, meaning that it's an issue within the cupula or within that ampulla. Okay. And then the other means that it's a canal lithiasis, meaning that the issue is within the canal. So I want you to understand with BPPV, you can have vertigo or that lightheadedness or nausea or dizziness with the change in your head position. Sometimes a person can have the vertigo or the equilibrium or not. They can have the nausea and the vomiting, or they might not have it. It depends on how severe the issue is. If you have that otoconia that's adhering or stuck within or inside of the cupula, you have that cupulolithiasis. And normally we can tell the difference when we do the Dix Hall pike. It depends on how long the nystagmus with the eyeballs last. So if a patient has that nystagmus and it's going for more than a minute or 60 seconds, then we diagnose that patient as having a cupulolithiasis. If you do that Dix Hall pike and you see where the symptoms of the patient last less than 60 seconds, and it's usually kind of short, like it might be 10 seconds, it might be 30 seconds. They have canal lithiasis. So there's a timing factor involved when we're diagnosing the canal or if it's within the cupula for BPPV. And then you have either a unilateral hypofunction or a bilateral hypofunction. So when you have a unilateral hypofunction, it is about the receptor. It's the hair cell, and it's whether or not it's getting enough input. And usually with a hypofunction, the hair cell is not getting enough input for some reason or another. And that has to do with whether or not that person may have suffered from some type of virus, some type of trauma, or some type of vascular incident, like maybe some type of stroke or something of that sort. When it comes to bilateral hypofunction, because unilateral ones are most common, when it's bilateral, it's normally going to be due to some type of toxicity. So it might be some type of issue with a medication the patient's taking, or the patient could have something going on systemically, such as a meningitis, some type of autoimmune disease, a tumor to cranial nerve number 8, and small strokes or TIAs, they're called transient ischemic episodes within the brain that's cutting off that vascular supply to the vestibular system. Okay. Usually with those hypofunctions and a little bit, sometimes with BPPV, a person they'll think they have images jumping or moving within their visual field. That's called oscillopsia. They the and the things are really just stationary. So like let's say if you looked at your wall and you see the exit sign, it'll look as if the exit sign is kind of moving from left to right or kind of bouncing around somewhat, when in actuality it's really stationary. So that's what I mean by oscillopsia. And with the ototoxicity or with the issue with pharmacology or maybe too much pharmacology or just something toxic, normally that occurs when like I said, when there's an issue with medication, allergic response to medication that's affecting the inner ear. And what it does is it destroys your hair cells. So there's a lot of little different things that are going on with all of these. What you need to remember or understand is that the mechanical has to do with motion and activity, and it's an insult on the otoliths or on the semicircular canals. And with unilateral hypofunction or bilateral hypofunction, it more or less has to deal with the trauma or what happened. Unilateral is going to affect one ear, bilateral is going to affect both ears. I cannot trick you. There's no such thing as a hyperfunction, so don't look for anything like that. It doesn't exist. Now, when the issue is more central, it's normally going to be due to a CVA or a stroke. The most common ones are the ones that involve the ICA or the anterior inferior cerebellar artery, as well as the pica, which is the posterior inferior cerebellar artery, or the vertebral artery. It can often be from vertebrobasilar insufficiency as well. It could be from a TBI or some type of head injury where it's against the inner ear. And then that last one, MS, stands for multiple sclerosis. So, as you can see, when there are central nervous system issues, and or central vestibular system issues, the pathology, as far as if it's from lack of blood supply, has to do with the supply to the from the posterior aspect of the brain. If you think about like the circle of Willis, all of those are the circle of Willis, or even just the vascular supply, this tying in and scaffolding from what we had from module one, that's all posterior blood supply to the brain. And that's what's primarily going to be involved. So here is just a synopsis of the vestibular canal testing for you. And this is also found in your asynchronous video material as well. It goes over the Dix-Hall-Pike, and it tells you that that's the test for the posterior and anterior canal. You have the supine roll test or the Paganini-McClure maneuver. Those are used interchangeably. So sometimes you might see the Paganini-McClure, and oftentimes you'll just see the roll test. And that's going to test for your horizontal canal dysfunction. As far as interventions, I think for you guys that interventions are a little bit above entry level, but I did want to make sure I discussed it or highlighted it just a little bit. So as far as with canal issues, when it is canal lithiasis, it can be anterior, it can be posterior, but it's for the anterior and posterior canals, not for the horizontal. It's called an Epley maneuver, and it's used to treat canal lithiasis. So I have that there for you. So I would use the Epley maneuver if there was an issue with the anterior semicircular canal or the posterior semicircular canal. If it was an issue within the cupula, where the otoconia are kind of adhered to the cupula, then I'm going to use the Samant maneuver or that liberatory maneuver. So that's why I put to treat cupulolithiasis there. But that is still just to treat the anterior and or the posterior semicircular canals. I use a totally different maneuver and test in order to treat the horizontal. And then as far as habituation type exercises, we do the Brandt Duroff exercises for that. So here's another knowledge check for you. A patient reports a sensation of spinning and imbalance. The symptoms began after a recent upper respiratory infection. Examination reveals spontaneous nystagmus and oscillopsia, which is that jumping within the visual field. What is the most likely diagnosis based off of just the information that I've given you from the previous slides?
My guess is B.
Yeah, that's a good guess. It is unilateral vestibular hypofunction. I gave you a little bit of a rationale and highlighted that for you. So with unilateral vestibular hypofunctions, they often are going to follow viral infections. They're going to present with that nystagmus, with oscillopsia or thinking images are bouncing around in front of you, and postural instability, meaning you feel like you're going to fall. That's the imbalance. BPPV, in contrast, is more positional and causes, and central is going to cause, and central causes have added neurologic signs. So when they say central causes right there in the rationale, that means central vestibular system issues. So here are some diagnoses that I definitely went over in your async material. Please be sure to review those for testing purposes. Diagnoses for vestibular system are Meniere's disease. You have paralymphatic fistula. So I guess I'll start at the beginning. I think you guys said you didn't review any of this yet, hardly. When you have Meniere's disease is an increased accumulation of endolymph within the inner ear. And what it causes is a low frequency hearing loss with some episodic vertigo. The person feels as if their ear is really full. That's called an aural fullness. And an example of that is if you guys swim and you dunk your head underwater and you come up, it feels as if the water is still in your ears. And you kind of go to the side in order to get that water to pop out. And then they can have tinnitus or ringing in the ear. So with Meniere's disease, it's kind of special um, from a holistic standpoint or a non-surgical or interventive standpoint. You manage it with diet control. Okay, so that means that the person has to be educated on decreasing the amount of salt intake they have or sodium intake, unfortunately how much caffeine they have. So I can never have Meniere's disease or I'd go crazy because I have coffee multiple times a day. How much alcohol they're ingesting, and oftentimes they take diuretics. They can be used to kind of help drain fluid as well. The second one is a paralymphatic fistula. And this is basically an inner ear, middle ear issue. So, what happens is if there's some type of trauma, and sometimes it can even be congenital, who knows? There can be a rupture of the membranes that separate the inner ear from the middle ear. And so, what happens is you have that endolymph that's going to leak to and from that inner and middle ear. And that's going to cause you to have vertigo and it's going to cause you to have some hearing loss. Moving down to that vestibular schwannoma, that's a benign tumor, okay? And it's a benign tumor that compresses against cranial nerve number 8. And what happens is that person, the clinical symptoms, they feel disequilibrium or like they're going to fall or have imbalance. There's a progressive hearing loss that goes along with that, as well as ringing in the ears as well. The next one is just motion sickness. You feel like you're moving, but you're not. Like if you took a cruise and then it's over and you get off and you kind of still feel like you're floating, that's motion sickness, okay? And oftentimes that's more of a somatosensory disorder and it's treated with habituation exercises with eyes open and then eyes closed on a solid surface. The next one is just what it says. No splitting hairs there. It's just migraine related dizziness. So with this person, if they experience chronic migraines, they'll get vertigo, they'll get dizziness, they'll have that motion sickness, and oftentimes they are referred outward to a neurologist for treatment. If they see me, I'm probably just treating their symptoms, but in order to really treat that patient systemically, they have to see a neurologist. Multiple sclerosis can also affect cranial nerve number 8. If you guys understand or know anything about multiple sclerosis, it's basically a progressive degeneration of myelin that covers the axons of nerve cells. Okay, so what happens is with that degeneration that occurs, that person begins to have vestibular issues as well, and this affects cranial nerve number 8. And then you can have what we call multi-system atrophy, and that's usually shortened to MSA. And this is a progressive degeneration of just the nervous system. And usually it's going to affect the cerebellum, any of the subcortical structures. It's going to affect the cerebellum, it's going to affect the basal ganglia, it's going to affect the autonomic nervous system and cause dysfunction. It can also affect the cortical spinal pathways as well. So this person always appears very uncoordinated with a huge base of support when they're walking, and they're really ataxic. And then the last one is a cervicogenic dizziness. And cervicogenic dizziness is something that happens when you have some type of neck trauma, which is why it's called cervicogenic. So you could have a patient that develops both TMJ, temporomandibular joint issues, as well as vestibular issues if they've been in a car accident and their head whipped front to back or left to right and they now have neck pain. So, oftentimes, when you are evaluating someone for vestibular issues, you definitely have to check the cervical spine to make sure that that's not the cause of their dizziness. Okay, so let's talk about contraindications because we're always having to talk about safety at some point or other. Just take a look at this question. Which of the following do you think is a contraindication to initiating vestibular rehabilitation?
All of the above?
I can't, well, we'll talk about it because you see chronic Meniere's disease. Now, if it's acute Meniere's disease, then we don't treat acute Meniere's disease because they have to handle medically the fluid accumulation has to be handled, okay? But chronic Meniere's disease, we can treat. What about motion sensitivity? Doesn't that sound like the motion sickness from the last page as far as a diagnosis that we would treat? So we got to cross off motion sensitivity. We can treat that too. Now, history of migraine is different from their suffering from active migraines, right? If they have a history of migraine, they can still have that in their history, but still have some type of BPPV. So we'll cross that out. However, with sudden hearing loss, that is not always a vestibular issue. Sudden hearing loss with earfulness can be something a little bit different. So that one we have to watch out for. Okay. So, sudden hearing loss with fullness may indicate that paralymphatic fistula that we can't do anything about, or acute Meniere's disease that we really can't do anything about in the outpatient clinic. So, both of those, because we cannot do anything about them, but they do need a treatment, are considered to be contraindicated because we might make it worse, and we don't want to do that. So, I have them listed for you here what the contraindications are. Okay. So your contraindications are here. You can treat chronic Meniere's disease, but you can't treat acute. Uncontrolled migraines, we don't even want to look at them. Paralymphatic fistula, because we can't fix the opening between the inner and the middle ear. That membrane has to be fixed surgically. Sudden hearing loss, we don't know where that's coming from. If we don't know where it's coming from, it could be coming from somewhere else. So we're not going to handle that because we might make things worse. Same as with increased fullness or pressure in the inner ear. Severe ringing in the ear is different from that tinnitus that a person would feel. That might honestly be a symptom of something a lot worse with this patient that encompasses the entire central nervous system. So we're not going to handle that unless that person's referred to us by the neurologist. Patients that have had surgical procedures, and you have to be careful. If you treat a patient, or even if you have a patient that suffers some type of head trauma, like maybe they have a concussion because they fell or their helmet came off and they were hit during a football game. If you see where they're having clear fluid that's not snot coming out of their ears or their nose, that could potentially be a cerebrospinal fluid leak, and that is a medical emergency. So those are some of the things that you have to be careful of. But definitely after a surgical procedure, you have to be careful with CSF leaks. And then neck injuries. Are we all together with that? Because I'm ready to switch subjects, okay? But in a nutshell, that's vestibular system, both central and peripheral. I'm really just wanting you, like I said, to understand the neural anatomy of what's central and what's peripheral, and then kind of try to get comfortable with some of those diagnoses and understand the contraindications. And now we're going to switch over and we're going to talk about traumatic brain injuries. So here's my first question to you. Take a look at it. Which of the following is the leading cause of traumatic brain injury or TBI in the United States? What do you think?
Sports injuries?
You would think so, right? It's not sports injuries.
A. A.
Motor vehicle accidents? Those happen every day. Assaults happen every day, but the answer is falls. As far as the etiology, falls is the leading cause of someone having some type of brain injury, whether or not it's a concussion, whether or not it's considered a mild brain or a moderate or severe brain injury. Those are normally going to be the leading cause, falls, okay? So here is some of that prevalence and impact in etiology, okay? It's a leading cause, though, of injury related death and disability in young adults. And that is because young adults are involved in assaults, they're involved in motor vehicle accidents, and they are involved in sports injuries, right? So, as far as the leading cause of issues with your young adults, that's going to be their leading cause of some type of injury. And there's 1.7 million Americans each year that are affected by some type of traumatic brain injury. You have 50,000 that are going to die. And unfortunately, that's unfortunate. And you have, unfortunately, 300,000 that survive and are going to be hospitalized. And they might be categorized as having that severe brain injury that, it's heads or tails. It depends on how they recover from those, if they're going to have any type of permanent disability. So, with the cause, you have 32% from falls for traumatic brain injuries, motor vehicle accidents following at 19%, struck by or against, that's 18%. You have assaults that are 10%. And then, unfortunately, the most the ones that are at risk are going to be your young ones, 0 to 4. And oftentimes those TBIs are going to be from some type of abuse or some type of shaken baby syndrome. 25 years or less, just because it's youth, motor vehicle accidents. Sometimes, I hope I'm not insulting you guys, sometimes recklessness, oftentimes sports injuries. And then your aging adults, those greater than 65 years of age. Because what do aging adults do a lot? What do? They fall. So if you work in an outpatient clinic or you work in the acute care setting, you'll oftentimes see an elderly individual sitting there. They'll have this big old bump on their noggin or they'll have this big old shiner. And oftentimes it's because they have fallen and they have hit their head. I did have one patient though who had a shiner and he had a big old bump on his noggin because he was, I think, about 75 and he was redecorating. So he put up new cabinets in his kitchen and he didn't make sure that one was secure. So he's sitting there and it fell on him. Boom. And he ended up with a concussion and I had to treat him for that. You have 5.3 million Americans that live with the consequences of some type of traumatic brain injury. So now, as far as the pathophys for a brain injury, I call this my coup de contre coup or deceleration acceleration injury. So I say that because in literature, you will see that terminology kind of used interchangeably. If you hear coup de contre coup or you read it, they're talking about a TBI where that brain is sloshed from left to right. or front to back. Okay. Same with acceleration, deceleration, the same exact thing. So I love the image because it's basically telling you with an acceleration, deceleration, or a coup de contre coup how it starts. So you have your one in the middle where the head is sitting upright, right? And then look at what happens at two as the head is coming forward, then you have the back of the brain that it sloshes backwards, so it goes in opposite directions. So then if you look at three, you can see where that head is forward, went forward, the brain sloshed backwards. Okay. And then as the head comes back up, the opposite begins to happen, and then you get the pressure or the injury against the frontal component of the head. So that brain just gets thrown left to right. And you would think because of the meninges in there that it does serve some sort of protection, but it's only so much protection that the meninges and the cerebral spinal fluid can actually really give the brain when it's subject to trauma. So, you guys, it's important for you to understand the difference between a primary injury and a secondary injury and their complications. Okay. So, when someone has a primary injury, it's due to the direct assault against the brain tissue, brain matter. That's called parenchyma. Okay. When you have a secondary injury, that's due to the events that evolve over time from that initial or that primary injury. So you might have fluid on the brain, you might have loss of oxygen to the brain hypoxia, that edema, that's the fluid, or even elevated amounts of intracranial pressure caused from accumulation of cerebral spinal fluid. So you have to make sure that you're understanding the difference between the two, but we're going to just take a walk and delve into it a little bit more, okay? When you have that primary when you have that primary injury, that's due to that parenchyma or that brain tissue going under trauma. So it's due to brain tissue coming into contact with an object. Most of the time, that's the skull, or it can be against something external. Okay. That's that rapid acceleration and deceleration of the brain that causes that initial trauma. So there's a direct blow that may also cause damage directly at the site, but then it's going to cause an issue at the back of the brain as well. That's the coup de contre coup component of that. Okay. So I'm just making sure that you're understanding that. All right. So here is your knowledge check. You have a 22-year-old male who was admitted to the ICU after a motor vehicle accident and he is unconscious. He has no sleep wake cycles. He is vent dependent. His eyes remain closed and he shows no response to any type of auditory or visual stimuli. What is the most appropriate classification for this person's current state? Is
Coma?
he It is a coma. They have no awareness of what's going on around them and they are vent dependent. So a coma is characterized by the absence of arousal or being able to wake up. They have no sleep wake cycles. They have no cognitive or communicative function, and the patient's presentation matches that definition. So that's what I want you to see. Now, in module one, it's either module, no, yeah, module one, where we're talking about the physical therapy evaluation. In that section, it talks about the differences between those different stages, the vegetative state, the minimally conscious state, coma, and post traumatic amnesia. Make sure that you guys understand those terms, please. Okay. So now here's another one. You have a patient, and the patient is easily agitated. The patient shows aggression and is uncooperative for treatment. The patient is alert, but they are very much so confused and they have no short term memory whatsoever. What is the most appropriate Rancho level? And when I say Rancho, I'm talking about that Rancho Los Amigos levels of cognitive function. What level do you think they are in just based off of the descriptives that you have here?
Confused and agitated?
Yes, confused and agitated is correct. So with level four is very exciting to work in. It's not always the most rewarding for us as therapists, but it's nice to see them evolve from level 4 to 5 to 6 to 7 if they continue to progress that way. It's nice to see. So with level 4, you're going to notice that they are agitated, they are confused. They will not remember you from one treatment session to the next. And if they do, that is really, really good. With this particular person, you have to keep everything kind of the same. Don't change it until they become agitated. When they become agitated, make sure that you have something else, another activity in your toolbox, because with that agitation comes a lot of frustration with them. They might oftentimes become quite aggressive with you. There's a lot of foul language in this stage. Um, so it just depends on what you're going to get from this person. They're totally uninhibited. They have a huge issue with not being able to process external stimuli appropriately. So they're emotionally labile, meaning they can go 0 to 100 really quick. They can be calm, and then the next second you show them something and they can be in tears. So please make sure that you all cover the RLA levels of conscious cognitive function. In some texts, you might see where it says, okay, they only go to like level 8, but in other texts, they go all the way to level 10, which I like because it shows you how they progress from that level 1 through 3 of really no response to you at all to level 3 to 6. They're coming out of all of that lack. They're coming out of their coma, so you can really tell the difference, even though it's pretty brutal initially when you're treating them. So what I want to do is I want to show you, before you guys go on break, I want to show you at least one of these, and then I'll have you go on break after that. But Craig Hospital, oh my gosh, they did such a wonderful job of categorizing all of the stages and showing these awesome video clips of what each stage looks like. I'm going to start you here at levels 4, 5, and 6 because I think that those are the ones that trip up a lot of us therapists because we really have to be creative yet patient in these stages. And we have to think of and tie in our stages of motor learning and think about how best we need to give interventions or administer interventions to our patients. So you're going to see me kind of skip a little bit. I got to get to 4.12 here.
Progress depends on the severity of the injury. Rancho level 4, confused and agitated. During this phase of recovery, the brain is still in a state of low arousal and sleepiness, but outwardly, this is seen as severe agitation or restlessness. Your family member's agitation can take the form of hitting behaviors, foul language, yelling, or they may be unable to stay in one place for any length of time. Your family member may have a very short attention span. Your loved one does not have day to day memory, so everything is new to him or her each time it is said or happens. He or she is very confused and may make up stories to fill in the memory gaps. This is called confabulation. Your family member may also have significant sleep disturbances, leading to fatigue throughout the day. Helping your family member who is agitated and confused can be very challenging. The treatment program is focused on keeping your loved ones safe and reducing agitation and restlessness. This may include the use of a specialized bed or a one-on-one attendant for safety purposes. Goals are directed toward improving the ability to pay attention through the use of familiar tasks such as brushing teeth, writing their name, sorting objects by color, or by selecting simple activities they enjoy doing. Because the ability to pay attention is still the primary treatment goal at this time, it is best to keep activities simple and familiar rather than asking random or challenging questions. This will help in decreasing agitation. Here's an example of someone who is at Rancho level 4, confused and agitated. Hey, catch for me. 1.
Better have that number out for a reason.
2. We're counting together. Let's make it to 10.
Okay, or that's not my 10.
Here comes 3.
That's not my number though. I'll give it to you for a bigger number.
Get your hands ready. Here comes 3, 4. Here comes 5. Get your hands ready. 5, good catch. 6, 12, 13, 14, 15, 16. Catch with both hands. Here you go. 17. Catch with this hand. Get it ready.
Not supposed to have 2
18.
teams of catching anything.
2 more.
I'll just take it off.
And then we're going to do something else. 19. Last one. Here it comes. Whoa. 20. Throw back. Thanks. Okay.
Okay. So my question to you, what do you notice? What do you notice regarding her treatment intervention? Let's scaffold and tie this into interventions, motor learning, and the best way for our patient to learn here. So what did you notice about the treatment or intervention and the surroundings?
She tries to guide him after he doesn't want to do it. Keep
Okay.
doing it.
What else? There's some persistence there. Would you guys have stopped or do you keep going? He really needs a lot of those verbal cues, doesn't he? So that's one of the things that you see. You see a lot of verbal cues with one task. What else do you notice about this intervention?
She said she was counting to 10 and then she was at 20.
Okay, now I don't know why she did that. I would not have done that to him at all because what she did, and a lot of times we do this, we add as therapists a cog component or a cognitive component to when we're treating our patients, and but we still try to keep it as simplistic as possible. And so with her adding the numbers, that's what she did. What about the surroundings?
It was quiet.
It was quiet. So if we had to use our medical terms for that, what would we call that environment?
Controlled.
I'm sorry, I didn't hear you. Closed?
Controlled.
Controlled, but it's a controlled environment, but it is a closed environment. So remember in your didactic material, we talked about a closed environment versus that open environment. And when it's a closed environment, that assists your patient with being able to focus because they are highly impulsive, they are highly distracted. And if they were in that open environment, meaning they were in a treatment gym surrounded by other patients, there probably would have been a lot more agitation with him in that type of environment. So working with him in his hospital room is definitely intentional because of the stage that he's in. Okay, I'm gonna keep going here.
Aaron.
Good. Let's do another one.
It's okay. It's okay. Brittany.
Good.
That's my wife. That's my sister.
Spot on.
That's okay. You don't need to write my other sister's name out.
I won't. You're good.
Y'all see that kick right there?
One more, and then we'll take a break.
Okay. Okay. Give me your name.
This is a state. Starts with
I would rather have her name
Aaron. Listen.
and then I'll get escape.
Colorado. Finish it for me.
Colorado.
Beautiful.
I'll
Good.
quit. I will quit
Good job.
because I have 2.
Can we hit a balloon?
Okay, so what did you notice about that segment of his treatment?
His emotion changed pretty quick.
Correct. That's that emotional lability. So that's how you would term or how you would document that a patient was increasingly emotionally labile. labile within the treatment session, this visit. What else did you notice?
He seemed to be getting people mixed up,
Yes,
or
he's
like
getting
names mixed up.
absolutely. He's getting people mixed up. That has a lot to do with that whole deficit of memory. Very, very confused with it, very agitated. Do you see how she knew better? Did you see how far she sat from him? Because the first couple of kicks, I think were he might have been out of his head and agitated, but those first couple of kicks, I think were intentional. But then after that, he just started kicking. Did you notice that with all of that rough movement, he didn't fall out of that chair and that chair didn't tip over? So those chairs are also intentional. They have a nice heavy duty seat belt on them. And those chairs usually will tilt in space for you. Those are usually really good for patients that are not yet volitionally mobile, only because it helps to relieve a lot of pressure off of them. So you can tilt their chair in space. Um, you can also tilt it back, like you can also tilt it in hope of using it as a soft restraint because you can't easily get out of the chair. So oftentimes, if I know that I'm working with a patient that's really volatile, for their safety, I will tilt that chair back if I can at some point during their treatment session, but I also will use it for pressure relief as well. Okay, so I do have some more video footage to show you guys, but we'll go ahead. It's 9:30, so we'll go ahead and take our 15. And then when we come back, we'll recap that and then we'll go into treatment intervention for traumatic brain injury patients. Okay.
This one. Go out. Starts when you grab it. Look at this one.
I'm staying here.
You stayed in here?
No.
No bathroom breaks or anything?
Oh. Should hurt. The hell? Oh man. Have no more.
That time.
Hope you didn't need to use it again.
I got my one word phone. Hopefully Big Watch comes back and maybe some supplies on it. That would be nice. I heard that they got rebought.
Really?
Hmm? By Roses.
Forgot about that store. What a weird place.
I wonder what it would do if we started singing. Go for Hannah. Like opera singing.
I only know one opera,
Sing it.
but that's okay. I hear my version of Carmen.
Did you have Chris check your computer?
Yeah, he fixed it. He's a lot more willing to help than the IT people at my old job were.
That's good.
You would go to their office and they were playing like darts and like, I'm like, hey.
Yeah, I thought it was always just paper. Oh my gosh, how many pages of pathology is there?
See, it doesn't matter what chair you sit in.
Long enough, yeah.
There's no chair 100% comfortable.
That's what I thought was interesting during what was that class that we had last semester?
Anatomy?
The anatomy and kinesiology one. The disc, there was more disc pressure sitting than lying down. I just never thought of that.
You guys realize your conversation's being recorded, right?
There we
Oh
didn't.
my gosh.
Kind of creepy.
Don't think we said anything wild, so who knows? Ruby Ann might surprise us.
Really? Standing too close to a bomb.
Hey, you guys, we have a little bit of your break left. What classes have you guys had before this neuro class as far as treatment?
Fundamentals of treatment.
You've had the fundamentals of treatment. What have you guys gone over?
That was the big.
Oh, thick.
That was the big book, wasn't it?
We went over lots of things. I don't even
Is
know,
that
like,
where you guys learned about like transferring, mitosis, maxis, menesis, manual muscle testing, things like that?
Manual muscle testing yet.
That and the transfers was that first book, the
Please wait a
spiral
minute.
one.
I'm sorry to interrupt you. Did you say you guys have not learned manual muscle testing yet?
So we did.
no,
We did.
Oh, okay. That took me by
Yeah.
surprise. Okay, I'm sorry.
Not the max moderate. Did we?
We learned transfers in first semester.
Yeah, it was that spiral book. Yeah, but I don't remember the
Okay.
name of that book.
Oh, is that the what the it was a spiral book? Was it the Frank Pearson book? Do you remember who
We
the
had an
author was?
Hey, Tawana, they don't have the exact same books that CSI has.
Mm-hmm.
And was it like black on the bottom?
We had an intro.
It was like a spiral bound, right?
It was spiral bound, but I just can't remember the title.
The cover.
Mm-hmm.
Was it black on the bottom though?
It might have been, and then we also had that little slim intro to PTA book.
Mm-hmm. Okay. And then you guys you have the Kistner Colby, right? The 8th edition
Oh
or
yes,
7th? Okay. And I'm asking, of course I'm intentional. I'm asking for a reason, but it won't be until after we look at the rest of the videos, okay? Okay, so I'm gonna go ahead and kick back in. And what I want to go over now is what happens when that person segues into level 5. So just bear with me as I get my times together on this. Why is this right here? This shouldn't be right here. All right. Right. 5th, 1335. 13. Okay.
Allow you to continue to be the best support possible for your loved one. Rancho levels 5 through 6, confused and appropriate, non-agitated, and confused appropriate. When your family member is in Rancho levels 5 and 6, the recovery process has moved into a new phase. You see a marked improvement in your family member's ability to interact with you, but they are now in periods of recovery known as the post-traumatic confusional state. This means there will be severe cognitive limitations, especially in the areas of memory for new learning and executive functioning. Let's take a look at this phase more closely. Rancho level 5, confused, inappropriate, and non-agitated, is characterized by wakefulness with awareness and purposeful interactions between your family member and their surroundings. While your loved one may be able to perceive and put meaning to what they see and hear, it will still be difficult to complete various activities accurately. They do not have day-to-day memory, a condition that is called post-traumatic amnesia. Your family member shows better attention than previously, but continues to be highly distractible. They need step-by-step assistance to complete simple tasks such as brushing teeth or getting dressed. Because higher level cognitive processes are not functioning well yet, your family member needs maximum supervision for safety. They may have some awareness that things aren't right and attempt to wander off the rehabilitation unit with a vague intention of going home where things are familiar. They may repeat an action and get stuck on basic needs such as going home, going to bed, or going to the bathroom. Here's an example of someone who is at Rancho Level 5, confused, inappropriate, and non-agitated.
Good morning.
Good morning.
How are you?
I'm doing pretty good. How are you?
Good, Todd. So can you tell me what the day is today?
16th
16th of what month?
January.
Good. Well, what's the day of the week?
I'd say Monday.
Is today Monday?
That's thanks to me.
Are you guessing?
I am kinda.
Kind of guessing.
'Cause it feels like a Thursday.
Does it?
Yes.
Why is that?
This leg tells me.
Oh, okay.
I don't know why.
Your body talks to you.
Yes, it does.
It tells you what the day of the week
A
is?
lot of times it tells me no. Like, don't do that. Okay.
Oh.
A lot of times it's this leg.
You tell when you're getting riled up?
Yep. I can feel it. This hand.
Right.
This hand will do this. I don't know why.
It gets kind of crampy?
And it does this. It closes. I don't know why. And then I can feel this finger.
Mm-hmm.
But it feels like it's doing this and it's not. It's just there.
All right. What's the name of this place?
Greg's,
And what state is this?
Montana.
Are you in Montana?
Yes.
This is Colorado.
Colorado.
Craig Hospital in Colorado.
I'm good with that.
All right. Where are you from?
Big Lake.
Now, are you leaving Craig Hospital soon?
Hopefully.
When?
When I go home.
Do you go home this week?
That'd be nice.
You're going to another rehabilitation program
Yes.
back in Texas.
Yes. That'd be nice.
You know what you're going to be working on?
The head. A lot of times it tells me no. But I do stuff anyways.
Tell me what's wrong with your head.
It tells me no. I'll think about doing something. My head will say, no, don't do it. But I want to. I don't know why. It's weird.
It's weird.
And I can feel it in this left hand.
So there's like a disconnection between your head
Yeah.
and your body and what it does?
Yeah.
Is that what you're saying?
Yeah.
What do you do to fix that?
This. I don't know why. But it makes me stop.
Okay.
What would you do if your car was broken down?
I got bus. My car broke.
But what would you do to help? That's if you were running late to work. What if you were just on the way to the grocery store?
You know
and
what,
your
you
car broke
guys,
down?
this is Gino. This is Gino. I'm sorry. I have to pause this and go back because he is now in the stage 5, but I want you to see his behavior when he was in a stage 4. So that you can see the evolution of the levels, okay? No, this is the same person, yeah. He had surgery.
Let's try one more time, okay? Can you hit it back? Thanks. Ready? Nice.
Let's go.
Do you need a towel?
No.
No?
Bitch.
Okay, I'm gonna
Sorry
grab
for
one
the
anyway.
language.
Here you go. Can you sit up for me, please? Gino, can you touch?
Go.
Okay, we're gonna go in a minute. Can you touch your nose? Give me a thumbs up. Can you touch your ear? Good. Close your eyes. Good. Gino, do you know why you're in the hospital? Gino, can you look at me? Whoop, let's sit in your chair. Can you put your leg back down, please? All right, you want to go, huh? I'm going to tell you a story.
Okay, I just wanted you to see that. So now you can see how he has matured within the RLA levels. And I'm telling you, Stage 4, they cannot remember their behavior at all. But you, as the treating clinician, you remember everything. And so it's really nice to see how they evolve along the way. Now I can go back here. You find him. He said, I thought it was the same guy. It looked like he had surgery, but let's see. But this is really what happens when they switch.
Is that what you're saying?
Yeah.
What do you do to fix that?
This. I don't know why. But it makes me stop.
Okay.
What would you do if your car was broken down?
I count the bus.
No, maybe
The
it's
bus
different.
before it broke.
But what would you do to help? That's if you were running late to work. What if you were just on the way to the grocery store and your car broke down?
Yeah, go talk to somebody.
Go talk to who?
Somebody.
Someone, meaning
Yeah. Clever.
maybe you could call somebody.
Yes.
Who would you call?
Jane Johnson.
Okay, you would call your wife.
Yes.
Okay. Maybe AAA. Some people would call AAA or a towing service. Okay.
Yes.
Can you name all the suits for me?
Spades, house.
Look, what's this one? Let's start over here.
Diamonds.
Mm-hmm.
Spades. House. Club.
Nice job. So what I want you to do is I want you to separate these by suits. Okay, so I'm going to put the pile right here. So you grab the card and then look at the suit and put it on the right one.
On the card. Parents. And then.
So these are hearts
Yeah.
and this is a diamond. Can you put that on the diamond?
Let's see.
Nice job.
Thanks.
Go ahead and grab another card.
Okay. Spades. Spades.
Nice work.
Okay, so with both of those patients, this patient here and then the young man in the previous vignette that he said this, but then this makes him, stop. What did you notice about their behavior? I'm hoping that you notice that as the levels increase from that 4 to that 5, there's still a lot of cognitive deficits that occur with that person, still behavioral. Oftentimes, what you see as far as the impairments, you're going to see a lot of the behavioral and the cognitive impairments. As far as motor impairments that we physical therapists work with, sometimes you'll find that they're highly mobile. Oftentimes we have to slow them down. There are some patients who will develop a lot of tone issues, such as spasticity and things like that. And those are the things that we have to pay attention to, because if the spasticity is in their lower extremities, then there's going to be some type of gait deviation or impairment. If they develop heterotrophic ossifications, which is the calcific or calcium formation within soft tissue surfaces of the body or in the muscle, then they have a limitation with range of motion. We'll talk about that one a little bit later. But as you can see, this is an interdisciplinary team issue. And so there's a lot of collaboration between speech, between OT, and between physical therapy. And so if this is an OT or speech language pathologist, and I would not dare to do it here unless we were working on sitting balance, but to have him performing static balance and standing static balance and doing some type of cognitive treatment with the OT, he probably would not be able to tolerate that now. But as he advances through the levels, he should be able to tolerate that type of treatment. And now I want you guys to see what a level 6 looks like. Let's see, 22.
Distractions are kept to a minimum. Frequent rest breaks should be scheduled throughout the day. Rancho Level 6 confused but appropriate. Once your family member has progressed to Rancho Level 6 confused appropriate, they have emerged from post-traumatic amnesia. They are now showing some recall of what is happening on a day-to-day basis. Orientation to the date, where they are, how to get to different places on the hospital floor is improving, but occasional assistance may still be needed. At this stage of recovery, your family member is still in a post-traumatic cognitively impaired state. This is a result of ongoing impairments in the areas of attention, ability to process information accurately, memory, and executive functioning skills. Your loved one may both start and complete tasks with less assistance, but will still need additional time to do so. He or she is able to hold simple social conversations, but topics talked about will generally be about immediate needs and daily activities. At this level, deficits that are related to the specific areas of injury to the brain are able to be better evaluated. Although they can be noted in earlier levels, these are called focal injuries. Examples of focal injury deficits might include left or right-sided weakness, difficulty understanding what is said to them, or not being able to think of the words they want. Your rehabilitation team will be able to provide you with specific information regarding any focal injury deficits your family member may be experiencing. Here's an example of someone who is at Rancho Level 6, confused but appropriate.
There's another class you take too.
Occupational therapy?
Mhm. What's that class all about?
You know what? I don't remember.
That's all right. Is there a way something you could do to figure out?
I can write it down. The notes or what I read, what I did.
You're right. One way to help you remember what you do in your class is to write it down. Where would you write that?
The notes section on my planner.
Oh, so you could check out your planner to learn more about your classes?
Yeah.
Can you tell me about your plans for school?
Mm. I have to think about it.
Mm-hmm. So what are some options for you?
You start my senior year over again, or continue where I left off.
Mm-hmm. What do you think would be best for you right now?
GP?
Why?
Because I forgot most of the stuff.
Let's say you go back to school, you get there and you realize, oh no, you forgot your lunch. You have no money, you didn't bring your lunch. What would you do?
Wait until the next day.
You wouldn't eat? Oh, I couldn't do that. I'd be hungry. Let's say you are starving. What would you do to try to figure out some lunch for yourself?
Ask one of my friends if I can eat some of their lunch.
Mm-hmm.
All right, G, so tell us a little bit about some of the problems that you've been having since your brain.
So as you can see, they're still confused. They're not agitated, right? They are appropriate though. And you can carry on a simple conversation with them. But the issue is that even at that level 6, they're still at a point where they have a huge difficulty with problem solving. So with this particular patient, they still have to have some type of assistance or supervision. Definitely not at a stage within RLA where they are independent. So you have to make sure that your treatment interventions are appropriate for what stage your patient is at once again. Um, Oftentimes what you'll see is some of the patients stop at a stage and they never get to a next stage. That depends on the severity of their trauma. You have some that make it all the way to that last level. So I know you guys are in Florida, but in my area of Ohio, the we have a kiddo. Well, he's not a kiddo anymore. He's an adult now. He should kind of be, I think he should be in his 30s about now, if not 30. Yeah, he should be in his 30s, like 35 maybe. But we had a horrific bus accident with one of our D3 baseball teams. It was from Bluffton University, and their bus driver fell asleep when they were going to a game. And their bus, I think it fell off an overpass. There were not a lot of survivors, but one of the survivors that we had at my Trauma One hospital, I can say his name now, because it's not violating HIPAA. He's discharged and he's famous or whatever. His name was his Tim Berta, but you can Google his name and it'll come up. And basically, for us that work and we float from acute to acute rehab to outpatient, I pretty much saw him through each of his transitions from that severe acute stage all the way to his outpatient stage. And right now, he pretty much leads, a typical life that we would lead. I mean, he's independent. He has went back to school. He has his bachelor's degree. At one point, he wanted to go to nursing school. However, I don't know what happened where that's concerned. His gait is still a little bit hitchy the last time I saw him, but he's driving, he's decision making, he's problem solving. So he's doing all the things that, that regular 35-year-old individual would do. He's even working. So it's really nice when you see a success happen with a TBI that's that severe, but it took years to get him there. All right, so let's slide off of this one. Which one is this one?
It's fine. I just
Hello.
Googled them. That was almost 20 years ago.
Was it 20 years ago? Okay,
Yeah,
so he's
2000,
probably he's probably in his 40s then, maybe like 45, so I'm off by about 10 years.
okay, 2007.
Very nice guy, and a wonderful family. I mean, that support system was just fantastic for him. All right, so this is why I asked you guys as far as your rehab knowledge, your hands-on, what's in your toolbox, okay? So you guys know what a contracture is, right?
Yeah.
Oh, perfect. So what do you do for contractures? What do you do for contractures? What do you do to decrease the chances of a person getting contractures? And if they have contractures, what would you do?
Stretch.
You want to stretch? What type of stretching? Any specific type of stretching? If you had to stretch someone who had a flexion contracture at the elbow, what would you do?
Slow. Suzanne, I don't think she heard you. A slow stretch.
Yeah, stretch. What type of stretching would you do?
Static stretching.
Static? Have you guys ever heard of low load, long duration stretching? Have you heard of that?
We have.
Yeah.
Perfect. That's probably where I would go because you're going to get real tired when you're trying to stretch a contracture if you're just doing that regular, okay, I'm going to pull and I'm going to hold you in extension for 90 seconds and I'm going to do 3 sets. I'm going to do 3 of those. You're not going to get anywhere. You need to have something that's sustained with a low load, meaning that you're not yanking them real hard, but that low load, the extension of time, it's what's going to get that. So in your reading, you talked about, or in your reading and in the video lecture, I talked about splinting or what you call serial casting. And with serial casting, what you're doing with your patient is we have a casting tray in inpatient rehab. And once we perform that low load, long duration stretching, and we've gotten that patient to a new in range, we'll cast them. Just like if you broke your leg or your arm, we cast them in that new range so that now they have that. We try to maybe take them a little bit further into extension as long as it doesn't cause them pain. So then we keep that on for about a week. And then we take it off and we examine what they have as far as their new range. And then we might do some more low load, long duration stretching with them again, pulling them to another new range, hopefully. And then we cast them again. So that serial casting, that's something that can be done on an inpatient rehab basis, or I've seen it also done outpatient as well as splinting with your patient. You can have dynamic splinting where you work with a durable medical equipment company and they'll give you maybe an extension brace. So there are definitely different things to use. What else other than stretching? We've already talked about stretching. What else would you do with your patient to prevent or avoid contractures?
Correct positioning.
Positioning is awesome. So you want to make sure that you're targeting them being positioned away from or off of offsetting bony prominences. You want to make sure that when you're positioning your patient, that you're positioning them more so in extension, right? Through the extremities. You want to make sure if their legs scissor or a double deduct that you putting a pillow between their knees to decrease that risk. With the feet, you want to make sure that you're keeping them in a neutral position between dorsiflexion and plantar flexion. So oftentimes you can use night splinting for their feet to keep their toes pointing up towards the ceiling. So positioning is cool. What goes along with positioning, especially when your patient is in an acute setting and they really can't move themselves? That's the hint.
Make sure to move them every so often.
Yep, every 2 hours. When they're in the acute care setting, you want to make sure that that patient is getting turned every 2 hours or so. So what you'll find at the head of their bed against the wall is usually some type of turning schedule, and this is usually coordinated with the other members of your interdisciplinary team, being it the OT, you as the PT, definitely the nursing staff. Okay, so of course, these are some things that you want to think about. Along with that, if they can get out any active range of motion or active assistive range of motion, that's also something to think about. When you're performing your stretching or your passive range of motion, you can use techniques like the hold relax or contract relax. Are those terms that you guys have been over before?
Yes.
Perfect. Okay. So definitely those types of things would help with that. So now let's go ahead and let's talk about pressure ulcers. Some of that is quite similar, right? So what are we going to do to prevent pressure ulcers from occurring with our patients?
Correct positioning and putting pillows underneath the butt.
Hmm. What type of
Rotating.
perfect rotating, having them on a schedule? What else? Any special equipment, maybe?
Special bed.
Special bed. What's so special about the bed?
A blow up bed.
The mattress with like an air mattress.
Yes.
Sometimes, depending on how acute the patient is, they can be in that on that air mattress. It can rotate for them, especially if they're in the ICU, the neurologic ICU. Definitely for those, when you go on your clinicals with those air mattresses, they are very much so non-compliant. So when you're doing transfers with that patient to get them out of bed, remember that you probably have to let the air out, but that's usually easy. That's the press of a button. You want to make sure that you're promoting proper skincare. And this is usually something that is coordinated with the nursing staff. But we also want to make sure with their tissue that when we are performing things with them, that we're not causing some type of breakage in their skin that can lead to some type of ulceration as well. So that's to avoid shearing with them. Like when you're sliding them across, like from one surface to the other, you have to make sure that you avoid those shear forces. What do you guys know about pressure relief, especially for your wheelchair bound patients? What we talked about bed bound and we talked about the fact that we have them on a turning schedule, but what are you doing for that patient that's in that wheelchair? Let's say they have therapy. They're qualifying for therapy 3 hours a day, 3 hours in the morning, and sometimes they might have 3 hours in the afternoon. It just depends. And so they're up and they're in that wheelchair. What are you gonna do as far as pressure ulcer prevention when they're in the chair all day in acute rehab?
Seat cushion.
Seat cushion, definitely. Lots of times those are those Rojo cushions. What else?
Weight shifting.
Weight shifting or pressure. We call it the pressure relief. How often should pressure relief be done with your wheelchair bound patient?
15 minutes.
Yep, every like 10 to 15 minutes. Perfect. And you're going to work on mobility with that person in range of motion. So, proper positioning while sitting and in bed to protect bony prominences, use of specialized cushions and mattresses, proper skin care, position changes every 10 to 15 minutes, and education on proper nutrition. That usually is going to come from nursing as well. But we need to make sure that our patient is eating between PT in OT. You come in, you see that patient with a full tray, and it's been like 20 minutes in for lunch. You might want to center your therapy around them actually eating their lunch. Mobility and range of motion. So now, heterotrophic ossifications is something that's real with traumatic brain injured individuals. HOs are usually going to develop in the hip region primarily, and sometimes within the shoulder girdle or shoulder musculature. I have personally seen it develop quite rapidly within hip musculature when that patient is in that subacute to chronic stages of their traumatic brain injury. And what happens is they begin to have like it looks like a retracted pelvis. So when they walk, they seem they seem very asymmetrical with that hip giving the involved limb a longer limb position. So you'll see that lateral whip. You'll see a bit of vaulting in order to clear that leg that they think's longer because they just have no hip flexion there anymore because of the heterotrophic ossifications that develop there. Now, those are calcific deposits that develop within muscle or soft tissue, especially in the hip and the shoulder joints. So I just want to make sure that I go over that, or hip musculature and shoulder musculature, I should say. So, as far as when you are working with someone and they develop heterotrophic ossifications, you can't be aggressive with them with their stretching. They're going to experience a loss of range of motion, but you can't be aggressive with the stretching or you might damage the muscle tissue. So, while you can perform passive range of motion, no stretching, and you cannot be aggressive. And so, what you'll normally do is functional range of motion. So, that's basically what the patient is doing actively. Um, and then I put where you would find it, okay? So, now with your patient that has DVTs, what's a DVT?
Blood clot in the extremities.
Yes, the DVT is going to be a blood clot in the extremities. Do you guys know how to avoid that? How would you prevent? What are our interventions in therapy?
Elevation, compression socks.
Yep, elevation, compression socks, binders, the EPC cuffs if they're in the acute care setting, and sometimes even when they're in the inpatient rehab setting. Okay. So moving on, you also have tone, okay? Usually you're going to see a lot of clonus, a lot of that shaking with the lower extremities. That's that spasticity. What are we going to do? Can you think of things that we can do to inhibit tone? Have you guys gotten that far in lab yet? Where you talked
No.
about PNF techniques and prevention of tone. Okay. So when you're trying to prevent tone, whether or not it's in that spasticity or that clonus that's in the upper extremity or in the lower extremities, and I think I had a handful of slides regarding tone and spasticity and rigidity in your module one. It's definitely in your sync session post materials. But weight bearing on the involved limb will help to limit or inhibit that spasticity or tone, attempting to take your patient through diagonal patterns, those PNF patterns, okay? Those will take the patient out of tone, like taking them out of that flexor tone pattern. What I call the 3 R's for relaxation: rocking, rolling, and rotation. Neutral warmth. A warm blanket does a lot to decrease tone and spasticity in a patient. Cold, kind of up in the air. Most people don't like cold. Cold serves as a facilitative technique and inhibitory. When you're using it to inhibit, it's just going to decrease the amount of neuronal activity and synaptic firing that occurs physiologically within the muscle. And then the last one, which I like to use in connection with range of motion, is deep pressure and sustained holds, taking the patient out of their spastic synergistic patterning in order to give them extension and relieve a lot of that. So that's the end of my sync session. But I still want to share my screen with you for just a second. Well, do you guys have any questions so far? You guys good? All right. So I gave you this. I have not put it in your material yet. I will put it in there after lecture, but I wanted to make sure that I talked about it with you first. So this is what I call an exam blueprint. This is directly connected to your midterm. You do have a study guide for your midterm. I've given you pretty much all of the information that you need to be successful for your midterm. You have it. You have all of the study guides I'm going to provide for you for the modules. You just don't have module 4 yet. You will probably have that at the end of today, or definitely by Friday. But what you have on your midterm are 70 wonderful questions. So you have 70 items, right? In addition, I gave you the module that you can refer to for your information. And right here, while it is not the answer, it tells you where you need to focus. So you have one item on your test that focuses on stages of motor learning. That means you have one question that's focused on stages of motor learning. You have a question that's focused on stroke risk factors. And while I didn't tell you the answer, you want to know what you need to study for. So I've given you a blueprint to give you specific information on what you need to study for. It's not the answers, but you do have to pay attention to these items, or you will not be successful on the test. You have to know what the clinical presentation of a right hemispheric stroke lesion is. If it's affecting the right hemisphere, what are you going to see? Atypical gait, that's all in your async material in regards to locomotor training. That's where it is, and that's located in module 2. There's another stages of motor learning question. So do you guys kind of catch the gist of where I'm going with this?
Mm-hmm.
Okay, perfect, perfect. I just want to make sure that while you guys have me available, that we have clarity on both ends and you're understanding how this midterm is going to go. There are matching. There are some fill-in essay type questions as well, but the majority is multiple choice. Please make sure that you pay attention with any imaging, that you pay attention to what imaging I provided for you. There's a lot of new material on it. There's a lot of module 1 neuroanatomy on it. But pretty much when I say neuroanatomical structures or neuroanatomy structures, that can cover anything. It can be about the thalamus or the hypothalamus, or it can be about a certain lobe within the brain and what it does and its function. Brain fibers. We talked about brain fibers in the neuroanatomy component in module 1. There's a couple of environmental design type questions. So giving you a blueprint of where you need to focus is basically the gist of this document. That cool? You guys good with that? Now you have this in addition to your true study guides as well, in order to help guide you as you're studying the next couple of weeks. The test is it's 70 questions, but it's a 2.5 hour test. So if there's anyone that has extended time, you'll have extended time off of that 2.5 hours. It probably won't take you the whole 2.5 hours, depending on how proficient you are with getting through the test, but that's the amount of time I'm giving you, okay? About a minute and a half for each multiple choice and about 2 minutes for my fill-ins.
Our midterm is week 6 for your class, correct?
Correct.
Okay.
Which one? 2 weeks from tomorrow.
Okay. So we're
Is
taking
it,
on Thursday.
I'm sorry, is it not on the syllabus?
No, I
Denise,
just wanted to make sure because I remember you saying that the first week of class, but I just wanted to clarify.
oh yes, week 6. Thank you.
Okay.
That was a good question.
Thank you.
Okay. All right, gang. Well, that's all I had for you today. You have any questions?
No, ma'am.
All right. Okay, I think that I'm the one that has to sign off first, right? Because I think this is logged in through Taylor's team. So, okay, you guys know my email. Hit me up if you have any questions or any issues. And you guys have been doing really well with your discussions. I just wanted to give you some verbal feedback on that.
Oh, thank
Okay.
you.
Thank you.
Okay, take care.
You too.
Uh-huh. All right, I just stopped sharing and then where am I? I'm a cursor. Here we go.